Alrighty, I will start the conversation. On behalf of the French American Foundation, I'm very pleased today to introduce our discussion on healthcare during the COVID era, which will be led by Tom Lee and moderated by Ann Carpenter. This is a special webinar for our community because it's led by two alumni of the Young Leaders Program, and it's the first event of the year to celebrate the 40th anniversary of the program. The Young Leaders Program, as many of you on this call know, began in 1981 and over the past 4 decades has developed an impressive network of leaders in France and the United States across many fields who come together to discuss issues of common concern and to strengthen the French-American relationship. So we're really happy to come together today, not only to learn something new, but also to celebrate the accomplishments of our alumni community. And we'll be hearing a lot from Tom Lee. And I will first, though, introduce our moderator, Ann Carpenter. Ann was a young leader in 2012, and she is Senior Director of the Imaging Platform at the Broad Institute of MIT and Harvard, where she's also an institute scientist. She has a background in cell biology, microscopy, and computational biology. And her expertise is in developing and applying methods for extracting quantitative information from biological images. She and her team developed Cell Profiler, which is the first open source high throughput cell image analysis software. And she was recently named to the top 100 list of AI leaders in drug discovery and healthcare by Deep Knowledge Analytics. And she's also an honorary fellow of the Royal Microscopical Society. So, Anne, thank you for being with us. And I will pass it to you to introduce Tom to get the conversation flowing.
Welcome, everyone. I'm really excited to be able to learn from what Tom has to say today. He's the CEO and founder of Galileo, which is a digital-first company aiming to bring healthcare to all populations, affordable, including complex and underserved populations. He has been working in the past on things like apps that help doctors to reduce their medical errors. He's created One Medical Group, which is a national model for tech-enabled primary care. So this merging of healthcare and technology, I'm really excited to learn with all of you, learn a bit more about. You can see in his career, he's been really driven by just elevating the quality of healthcare for all. And during this era of COVID, it's become very clear the discrepancies that are often faced by different populations as they try to maintain their health. So Tom, please, if you wouldn't mind giving us a bit of an introduction to the topic today, the primary healthcare landscape and access to care, then we can take it from there with some discussion and questions.
Great. No, thanks, Anne, and nice to connect with the French American Foundation and ecosystem. Maybe, obviously healthcare is top of mind these days for obvious reasons. I can talk a little bit more about background and context, and healthcare is so broad of a concept, especially in the lens of the US and or France. So happy to kind of broaden the dialogue depending on where people want to go. But briefly, the way to think about my background and maybe topics we can cover is I come at it from a clinician's lens. I did my training as an academic generalist, focused in primary care in both rural and urban markets. I've seen pretty much almost every context of care, particularly in the United States. So rural medicine in the Northwest, from Alaska, Montana, Idaho, to kind of this quaternary care system in Boston. So kind of the best of science and technology applied in kind of life science and medicine. In that journey, it was pretty apparent to me that a lot of well-intentioned people were victim of a broken system where patients were not getting the optimal care that we could deliver. And everybody I asked at the time was like, I don't know why we do what we do, but this is what we do. And if you ask any patient or clinician, is this optimal? Everybody would say far from it. And we were spending more than any other country on healthcare, so it just made sense that something was not right. And so I began my entrepreneurial journey then. I got a business degree and then really focused on building out companies that improve the quality and cost of healthcare. And through that journey, I've started to understand what we understand now as the healthcare system, what I call the industrialized healthcare complex. But it is a system built through happenstance, not by intent, and it has resulted in a lot of the woes that we see in general out of the American system, but frankly are seen in every healthcare system at some level, just in different volumes. But through my journey, I built out a mobile health company called Hippocrates that improved point of care decision making among physicians at the point of care. That was broadly used. Later, a company called One Medical, which at the time was about as unsexy as could be in the venture community. You know, primary care services, healthcare services were not really of interest to technology or investors, and certainly primary care was kind of low man on totem pole in terms of specialty areas. But I knew its fundamental importance in terms of improving patient care and maintaining longitudinal relationships based on my background. And we built out One Medical as a model that's scaled nationally. It's still young and growing, but it's still quite a substantial business today. And more recently, a couple years ago, started working on my next business called Galileo. And unlike my two prior businesses, which were, hey, I'm going to take a cut on the edges and start to invest deeper in fixing the healthcare system, Galileo is more deliberately designed to fix the healthcare system. And by that, I mean, if you think about healthcare and where a lot of the elements that are broken are, it's in the clinical care model where we can't have access to the right expertise effectively and in a coordinated fashion with anybody else. And so what we wanted to do was re-examine how healthcare delivery could be re-examined for a future state in a future world using technology and the best of human-based clinical contact. So we've built out and designed the model. We've now launched it and are starting to commercialize it. But we have early indicators suggest that this model is not just incrementally better, but dramatically better and much lower cost, which if you believe healthcare is inefficient, should be a natural outcome of some innovative model. But it's really hard to design this because of the complexity of the healthcare system. So with that, I think we've covered enough territory. We have to go into deeper areas wherever there might be interest.
All right, thanks for that introduction. Yeah, maybe I can begin with probing a bit more to draw some of the content out of what you've accomplished and how you've managed to do it. So maybe we could begin with Galileo. Tell us, what exactly is it? What does it do? Where are the advantages compared to the old-fashioned way?
Yeah, I think to understand kind of how different Galileo is, it helps to be a clinician. So I'll kind of walk you through what a typical clinical process is in what I call current medicine and how Galileo is different. If you think about modern healthcare, which is really a little over 100 years old when science became a discipline within the medical industry, and teaching and training institutions became a thing, right, in the early 1900s. That's about how long our institutions have been around for. And prior to that, a lot of it was art and less science, right? And so the traditional model today is considered the gold standard of care, which is a one-on-one doctor visit, right? The doctor has knowledge and expertise. You spend time with that clinician. They use their wisdom and experience, and they make a diagnosis and they treat you. And 100 years ago, that might have been a great model, right? There was limited science. A lot of care was relationship-oriented, understanding the context, explaining things, and providing reassurance. And so in the old model of care, that would have worked great. Today,
and I should say, they could even stop by your house, which is
exactly
a very nice feature we're missing these days.
Exactly. And so medicine then was a much more relationship than science and much more art than science. The challenge has been over the last 100 years, has been extraordinary advances in scientific understanding of the body beyond even just traditional medicine, Western medicine, but into life sciences, into integrative medicine, lifestyle medicine. And so our understanding of health and illness has broadened exponentially. Our training hasn't changed. Our memories have not grown exponentially. And so today, when you visit a gold standard doctor, whether it's a Mayo Clinic, Hopkins, or One Medical, or any individual physician, they're relying on their memory, typically in a very compressed time window, because of the payment architecture oddities in American healthcare. And so because of that narrowing of time, the rapid explosion of medical knowledge and the inability for any clinician to stay on top of that, most clinicians are pattern matching on common things, right? Common things are common. And so 80% of the time that might be fine, but 20% of the time, not so great. And if you talk to anybody in healthcare, everybody has a defect story. There's lots of defects that happen because it's not designed to be defect prone, right? Or there's too much information, too much complexity, and frankly, too much nuance to medicine. So with Galileo, we wanted to design a different way to diagnose in a different way to care people. And so I guess the way kind of I describe it is, if you were to visit a young physician with a clinical situation, that clinician is going to ask you 30 to 50 questions, some of them mundane, some of them kind of unrelated to your request, and they might come up with a meteor diagnosis, right? And you know it, right? You can kind of just feel it. If you see a young physician and they're asking and they're kind of hunting and pecking. And the power of the human brain is through experience, we become great at pattern matching. And so an experienced clinician is going to come in and interview you. They might ask 8 very specific questions. But with those 8, they've naturally, in their brain, sorted out the things that differentiate common from rare, A from B, D from F, and that process is called experience. And so what we're trying to do is understand that abstraction process and then put it into software and data processes so that the software better executes this more reliably in concert with clinicians, so they're working as a tandem. And so that's the spirit of it.
So it's not, you haven't produced a software product that is an artificial doctor, it sounds like. It sounds like this is an assistive tool that the clinician uses when they're interacting with a patient. And are they using it really
Correct.
in real time?
Yeah, so I think it's a great analog for broadly thinking about how you think about AI and machine learning in our society today, right? There's folks that are focused on the human experience and folks that are focusing on machine learning. We think that in complex areas like medicine, the hybrid approach is a preferred approach, at least for quite a long time, until the data becomes interesting and compelling enough to drive decisions. There's so much subtlety to what the human brain is able to infer through experience that it's really hard to get it from a purely machine learning perspective. So it is a more hybridized approach than what you see traditionally. Today in digital health, for example, you'll see pipes to doctors, video to another doctor on the other side. And that's the same as the traditional model, or a brick and mortar or video visit. It's the same type of interaction inferred on limited information. The machine learning side is, mining every single data point that might be possible and using algorithms in a black box fashion to try to infer what could be going on. And if anybody's ever tried them, they're not very accurate and they're not confidence inspiring, and you certainly wouldn't make a life-threatening decision based on it. So at some level, we're looking at blending the two together to offer more consistent, higher quality and learning product.
Yeah, and that's, I guess that's the question. Do you see this progressing to the point where it is largely automated?
Yeah, I think at some level, to make healthcare more affordable, we need to do a few things. One is to organize care better. So that's just a function of organizational design and who is caring for whom when. And then the second is, how do you make the use of a clinician's time, which is the most expensive ingredient in the healthcare ecosystem, more effective? And so through a combination of both of those, we think we can not only improve the quality, but reduce the cost of healthcare, not only for the US, but frankly on other countries as well.
Now I have a question about usability, because physicians often complain, I mean, every physician I've talked to complains about sort of the note-taking and the record keeping that they do, and that they feel they have to spend more time interacting, typing things in these days as opposed to interacting with their patients. So I'm curious about the user interface and how this digital tool it's improving their efficiency, but how is it avoiding that kind of a dynamic where the doctor feels like they're no longer interacting with the patient?
Yeah, so a couple of things. There's kind of two dimensions. How do you build a user interface that's more intuitive? And that's harder than people think, right? If you think about most software systems that people use, even something as simple as Zoom, people find it, not necessarily always intuitive. I think Zoom's more intuitive than most, but it's a pretty simple product. When you're looking at what we call workflow tools, things that capture data, document data, and order things, that's where the software starts to break down, because you're not just doing one thing repetitively, you're doing a whole myriad of complex things that depend on different forms of data and different forms of action. And so that's why most electronic health records are not well received by clinicians, and they slow people down, right? We have a background in software design, we have a background in clinical workflow, so we've designed our own, and it's much more effective and efficient than most. So in general, that's kind of one part of the equation. The second is, what is that human interface with the patient? And that's where we get into, a new modality of care, right? So if we were just trying to replicate the current model, you just do video-based visits like this, and it's not, it's not bad. But it won't improve the accuracy of your diagnoses. It won't improve the therapeutic efficacy of your diagnoses. The goal is to, we won't even know, right? Because we don't even measure it in clinical practice today. So a lot of medicine is still gray zone, right? It's subjective interpretations and experience and recollections. And so we don't know which doctor is better than another doctor, right? It's all inferred. So the difference with our system is we're using more structured data as part of the process. And we will know, not necessarily today, but over time, what data points are more material than others, which diagnoses are made more accurately and why, what therapeutic agents are more effective. So it's much more akin to research trials, but in the context of practice. And the clinician is given much more dramatic and material feedback to improve their practice dynamically, because it's captured, right, in the system, not inferred.
Yep. And so then you're not relying on the faulty human brain's memory, and some of our pattern matching is biased against certain demographic
Right.
groups, and so it sounds like you're avoiding some of those issues as well.
Right.
Tell us more about Hippocrates. What exactly does it do? It sounds like you're focusing in on the same kind of an issue, same kind of a let's assist the professional in doing what they're supposed to be doing.
Yeah, so, that's a bit ancient history, so people have context. It was originally launched on a Palm Pilot platform, wired sync through internet before there was mobile devices or really any kind of mobile connection. And, for folks that are tech savvy, the memory size was measured in kilobytes. So it was, so that was what we originally started with, but it became a viral hit among clinicians because it provided information that was needed at the point of care. And all this information existed, but it wasn't usable. They existed in big fat textbooks that nobody could ever reference quickly. And usually, were expressing in paragraphs what could be stated in 5 words. And so what we did was basically distill the product down into its core essence and provided that intelligence and knowledge to the clinician so they could make point of care decisions much more fast, quickly and accurately. And so that's pretty much what it was back then. It still is for the most part, but it's a point of care information tool. Yep.
I see. So a search functionality, but really geared towards this audience and providing just the minimal nuggets that they need to carry out their care.
Yeah, I mean, as an example, and if you're a patient today, you can install the application. I still think there's a free version of it, but there's this thing called multi-check, which is a way to check for drug interactions. So if you're taking, multiple medications, let's call it over 5 medications at a time, the number of permutations there is significant. So, and most clinicians wouldn't remember this, right? And so back to kind of how do you enhance clinicians' time? Well, you don't rely on their memories, you give them a tool that better encompasses it. And to give you how arcane the data was when we first started Hippocrates, the drug interaction data set was a little bit archaic. So depending on when a drug was released, drug A might interact with drug B, but if you looked up drug B's information, it doesn't interact with drug A. And so you have conflicting information. And so that is the challenge. And so to have to manually do that would be ridiculous, right? And to kind of adjudicate that. So we had experienced pharmacists work with us to then design that. And so you would just add in 3, 5, 10, 15 medications, and it would just automatically check for any cross-linking interactions and give you those interactions, which create a lot of harm to patients incidentally and unintentionally.
Yep.
So something as simple as that was pretty eye-opening from a technology perspective, but that's kind of basically what Hippocrates did. And, you know, it's sad, but it was, you know, leading drug interaction identification back then. Now it's more commonplace, but it's still widely used because of that and many other features.
Okay, and then let's dive into One Medical Group, which I think will start touching on the formal title of this discussion, primary healthcare, and especially in the COVID era. Tell us more about how One Medical is accomplishing its goals.
Yeah, so One Medical was started, 10, 15 years ago on the premise that primary care was broken and we needed a more sustainable model of primary care. If you think about it, it's the model of care that has the most relationships with more patients, makes more decisions on behalf of patients, but is typically under-resourced, and it's a very complex practice to manage and run. So generally, primary care docs, especially in the US, are just struggling to make kind of ends meet. And it's a combination of the complexity that primary care clinicians have to see, meaning a lot of breadth and complexity, but also just the amount of overhead in a traditional practice. So with One Medical, we basically redesigned the practice flow to make it more efficient, but more effective. And so that allows us to do same-day appointments, more time with patients, and that time was the key ingredient we added. Remember when we kind of talked about this old model of care where, you have your memory and then you have time, and that allows you to get a more accurate diagnosis. But because primary care was poorly reimbursed and a lot of practices were inefficient, that time and time got compressed. So the average primary care visit was 10, 15 minutes. And when you don't have as much time, you kind of have to make shortcuts in your clinical diagnosis, which results in lower quality, more expensive care. So we added time back into the equation at One Medical, and that's allowed us to kind of build a high touch model that's scaled, but also reduces total cost of care in terms of all the management of the patient. And so that model has continued to scale. We've built out a great team, and things that are lost in the equation of healthcare is it's a people business, it's a service business. And how many times have people been in a healthcare institution where they weren't treated very well? Information wasn't communicated. People were pretty gruff. They're talking about their vacation when you're waiting for a cancer diagnosis or not. There's a lot of really odd, insensitive things that happen in healthcare institutions, not because they're bad people, but it's just the system hasn't designed a high-touch model. Mm-hmm. And so what we focus on was not only the nuts and bolts of executing reliable care that is adding more time back into the doctor visit, but how it feels, right? Do people greet you warmly by your name? Do they take personal care of you? Do they try to understand your needs and share information in what we call a shared decision-making framework for clinical care? So it's not paternalistic top-down care, but shared decision-making that allows the decisions to be made in the context of you. And people take that for granted, but that's unfortunately beaten out of the average clinician because they don't have time. So right. When you're in survival mode, you lose empathy and you lose some of that ability to connect with patients.
Okay, so speaking of survival mode, can you touch on COVID's impact on the primary care model and what you see as coming out of this past year?
Yeah, so maybe we can shift gears a little bit to COVID, which is a little bit more present and top of mind. Obviously, huge impact to society, huge impact to patient lives. One Medical is a hybrid model. It's brick and mortar and virtual. So the power of that is we've been able to adapt, from a brick and mortar to a mostly virtual world during lockdown phase. In the now intermediate phase where we're doing some limited brick and mortar operations, That's beneficial. Why? So you can get vaccinated and you get tested. So this hybrid model works really well, and there aren't that many hybrid models of medical care that were designed to be hybrid. So at least in a COVID world for us, and I'm not active day to day with One Medical. I've since moved on, but the team is doing a fantastic job in managing all of these complexities. But I think we must be one of the top testers and vaccinators in the country as a medical group, right? Just given our breadth and scale. But again, that's it's just the nature of healthcare. Healthcare is highly fragmented and broken, and we're one of the more organized national medical groups on the front lines.
Yeah, yeah. Okay, now having developed these different applications of technology to medical care, I'd like to know more about what has gone badly. Are there instances where just basic human nature, you expected one thing and got another? Tell us about some of the things that went sideways in the designs and the developments that you've made so far.
Yeah, I mean, in the service business, there aren't a lot of big sideway events. With software, you go, oh, crap, Robinhood would be a classic example recently, but with technology, things scale so quickly, you can get a big veering off. With services, because it's humans and it's incremental, it's very rare that you have a big, oh geez, kind of situation. It's usually kind of a blossoming situation that you can identify before it's big, and then you can manage it. So I describe managing a service business as closer to gardening. Like, you're always managing the teams and the people and the organizations, and you're trying to, weed out things that aren't working well, but it's rarely gonna, hit you in the face like a technology company. And so you can kind of see things coming, and then you can try to manage, areas and pockets and move things around a little bit. I would say, the biggest thing for us within One Medical, and it's part of the inspiration for Galileo, is there's a limitation to what management can do to change what we call the translation of care, right? The standard of care in research might change instantaneously with a seminal article, but how long it propagates through the medical ecosystem can take years. And so what we wanted to do was shorten the translation leg from knowledge to practice. And so even at One Medical, you still have a translation leg because of just the human factors that it's dependent on, right? You got to A, get the provider's attention, B, convince them that this new thing is correct or not, C, habituate it if and when the patient is seen in the appropriate context, and then repeat it. So that takes a lot of memory and effort for standard of care to be translated in the medical system. And this is even just within one group, let alone the industry. So a lot of what we've been working on is how do you speed up that translation.
That's definitely a worthy goal. As somebody who's a scientist working more on the drug discovery end of the spectrum, we certainly feel like, well, it's great to advance clinical practice in some way, but you still have these pesky humans between you and the patient that need to actually implement things and make sure that they're safe and appropriate to a given circumstance. So it makes a lot of sense. We have a question in the chat from Megan Carroll. She wants to know, do you think post-pandemic the prevalence of virtual medicine, telemedicine, will remain and possibly expand?
Yeah, it's a great question, and it depends on which month you're polling the industry. I tend to be a bit more of a cynic, but obviously in a lockdown mode, in the absence of substitutes, almost everybody's using virtual medicine as a release valve, and in that you're seeing a kind of hype cycle there, and people are quoting thousands of % increases, but when you're not doing any virtual visits, it's, everything looks like a big number. So that's happening today. It certainly cracked the seal among providers and systems to think more openly about it and realize that the world doesn't come crashing down if you do video visits in telehealth. But there is a bit of a subtle reality that, and this is where the healthcare system becomes a little bit more of the issue. Payment models, the way organizations are structured, incentives are structured, don't necessarily reward video visits in the same way. And frankly, it's possible they shouldn't be, depending on what kind of care is given. So this gets a bit to the challenge of how healthcare is fractionated into payment units, right? When you think about services, if you call me up and ask me a question on the phone, does that matter if it's a video visit or a phone, or if you see me in person? In theory, it's the same unit of knowledge being shared. But the reimbursement architecture only allows that to be paid for if you see me in the office traditionally. Now, there's been government waivers and some other relaxing, of rules here that allow for that conversation to happen via video and get paid. Today, on par, right? It's the same. So that's why people are happy with it. But this is where it becomes challenging. Let's say you give me a call and we chat about the weather. And we talk about a little bit of stuff, but not about a lot of stuff. Should I get paid the same? Let's say, because it's so easy to call me, you call me 5 times in a day or 5 times in a month, whereas because you can't visit me in the office as frequently and it's a bit of a hassle, you don't go to the doctors often, should you get paid the same for each visit, 5 times a month? And so you can see that this becomes a slippery slope when it comes to reimbursement. And because of our reimbursement architecture, somebody's going to have to pay for that bill, right? And so if you're visiting the office twice a year, 3 times a year, and let's say, the insurance companies pay $100 for that visit. And now, because video visits on par, and man, it's just a simple click on my phone and I can talk to a doctor, why not? I have this, sore pinky, it's pretty easy. I'm just going to push my button and talk to you, and that goes to the system for $100. And then, I just wanted to talk to somebody, not feeling great today, another $100. So you can start to see that the incentive architecture and payment models start to change and insurance premiums go up, right? So that reckoning hasn't happened yet, and either reimbursement will go down or people will manage the criteria of what's appropriate to manage or not on video, or people will just go back to the office visit. So I think there's still a lot to be determined still. And in reality, as people get more comfortable with going out again and going to restaurants and seeing people in person, the office visit will come back. I don't think it's going to necessarily come back at the same levels, but I think there's still a broader question about how do you pay for these services realistically, because they're broken up into these weird pieces that get billed as codes that somebody else is paying for.
As opposed to an incentive structure that's based on patient outcomes. Is the patient healthy at the end of the year, no matter whether you spent 6 10-minute phone calls or multiple in-person visits?
Yeah, that is a bit of the challenge here. And I mean, again, I don't want to get overly political here, but it's really hard to pay on outcomes because outcomes are so deferred. And so, you really don't know necessarily it depends on how you define an outcome. And it's more about who gets to decide who pays whom what. And right now we've abdicated that to the insurance companies. And, if you were given $8,000 or $10,000 a year to spend on medical care personally, right, which is the concept of a voucher program, would you allocate those dollars more effectively for you, right? And is a video visit worth $30 or $100 to you? And, again, I don't want to get too much into political, but that's where you can allow people to decide a little bit more for themselves. But that's really hard when you've got a third-party reimbursement system that is basically covered by, employers and or government.
Yep. Let's go to a live question here from Arlette Laurent. If you'd like to unmute yourself. Are you able to unmute yourself? There we go.
Oh, thank you. I'm interested in Tom's reaction about payment because I've just been speaking, shall we say, to my lawyer, And he's charged me an awful lot. While talking about this and that, I happen to know him personally, but all right, you know, lawyers charges you by the minute, and they have a tick-tock thing on their telephone. I would imagine that you might consider for doctors a similar type of system if you're going to have a video call with them, or if you're just going to have a consultation on the telephone. What do you think about that?
I think it's a great suggestion. God forbid physicians are expensive as attorneys by the minute or hour, but we'll see, right? But yeah, you know, people say, how would you reform healthcare or insurance reimbursement? And one of the suggestions I posited a long time ago to, you know, different policymakers was time-based reimbursement, because it's less gameable, right? There are only so many hours in a day. There's so many minutes in a day. So it's easily, it's more readily, you can more readily detect fraud, right? It's a standard unit and measure that now both parties will value time more effectively because of it. And you could have different rates for different expertise, right? So if you were to do a reimbursement architecture through insurance, that would be one argument for time-based billing. So it's a good suggestion, frankly, that unfortunately healthcare is not necessarily decided on what would be rational. It's decided on what's politically feasible and tenable. And so therefore, you know, a lot of these kind of reform suggestions, you know, sit at the desk of the legislators in a stack of papers.
All right, feel free to raise your hand either by waving or the reaction button in Zoom. But we'll go back to the chat window. I'll assume if you type it in, you'd like me to read the question. So from Agnès Rameau, asks, how does one compete in the virtual care world given the increasing number of players who also use AI and research on patient data? E.g. RO, I don't know what that is, or even university healthcare system.
Yeah, so Roe is, you know, Roman, and it's one of these kind of convenience plays on, you know, what we call kind of vanity drugs to start, but trying to broaden. Roe in particular is trying to broaden to be more healthcare than just what I call vanity drugs, or, you know, kind of these lifestyle drugs. Not that they're, I'm not trying to put a judgment around it, but, you know, hair loss and propecia and, you know, some birth control kind of concepts. Anyway, things that sit outside of traditional insurance is kind of basically why a lot of these things have taken off, because it's more convenient. You don't require, you know, a lot of consultation. You just need a prescription. But it's a great question, which is, you know, how do you really compete in the virtual care world? A couple things. It kind of depends on what your lens is. If you're a traditional provider, it will be a part of the future one way or the other. So I think becoming facile with virtual care is a critical skill. Just like at some level, you know, seeing patients in a hospital became a critical skill for clinicians when the hospital was invented. When the phone was invented, being able to have a conversation and diagnose people via the phone. Same thing with virtual care. It's going to be the part of the future. It's like you might as well start to get used to the tools and technology of a traditional provider. If you're a virtual care provider competing among other virtual care providers, that is a challenge because you know, there it's a much more dynamic space. If you see, you know, kind of the world, you know, and let's maybe put the spectrum here. There's one end of the spectrum, which is physical everything, brick and mortar doctor visit. And then there's a spectrum over here, which is digital everything. You know, let's call it Google, or, you know, Amazon would be in the middle, but Google, where basically all the information is digital, there's no human involved, right? Virtual care, I think for quite a while, is going to be both, right? And so there you have a trend towards the right, which is, you know, anybody in a garage can point, you know, shoot at you with technology, right? And we're seeing the power of technology being able to swamp anything, you know, GameStop being kind of the most recent example. But technology moves much more rapidly and can sideswipe you. Brick and mortar you're not going to get hit by some practice in Buffalo if you live in Miami, right? The middle is where virtual care is going to be adjudicated. And so I think you have to be good at both to be a successful virtual care provider, if that helps. I know there's a lot of attention on AI, which is kind of the corollary here. I do think you have to be familiar and competent with AI. I'm not sure AI completely replaces this hybridized world for quite some time. Unless you happen to be in ophthalmology or radiology today, then I would be a little bit more concerned. But the visual machine learning companies are more threatening today than what I call clinical diagnostics. And that's because the endpoints are harder. And so where the endpoints are harder in medicine, that is where the standards of care are more clear, right? Oh, this is clearly retinitis because of these characteristics that can be quantified numerically. Therefore, the machine can get better at it faster, versus is this, lupus or rheumatoid arthritis, or, those are vague symptom-based. And I'm just adjusting my microphone. My bad. I sound weird.
Yeah, I think so. The audio cut out for a bit for me. I'm not sure if it was just me.
Okay, am I back now? Okay. Yes?
Yep, I'm fine now.
Cool. Oh, I don't know where I got cut off, but hopefully I finished enough of whatever I was blabbing about.
We can go to another question from Simon Duche in the chat window, who thanks you for your very insightful conversation so far. What's your perspective on more preventive healthcare as well as value-based payment, which we discussed? And does Galileo or other companies, One Medical, work towards such new approaches?
These are good questions. So, and they're related to a prior question. So when we talked about healthcare payment redesign, again, I'm not going to get overly political here, but the left generally views healthcare as one public good. The right generally views healthcare as one private good. And in reality, healthcare, in my mind, is 2 or 3 different types of goods. And so public health is a public good. Everybody benefits by somebody else getting a vaccine, or that tuberculosis person getting tuberculosis meds. So you want to make preventative care and or public health, or particularly public health, free, right? So vaccines and everything else. Similarly, it could be said about preventative care, right? That having a healthy, productive workforce and less sick results in a better, more thriving economy, so we all benefit, right? So you could argue that preventative health should also be a covered public good. Then there's other public good called the moral public good, and that one's the most charged and challenging, and it tends to get conflated with everything. But the statement basically is, in a country of wealth, it shouldn't be possible for somebody to go bankrupt because they get cancer and can't afford the medications, right? And so I think there's a moral public good that says we should cover people that, means test to some level of net assets, so that if something happens to them, that they're not going bankrupt, right? That's just doesn't feel decent. But everything in the middle, in theory, could be a private good, right? You get a voucher and you choose if you want to pay this for X treatment or pay Y for that treatment, or if you choose an office visit or a video visit, or if you see a nurse practitioner or an MD, you can choose that. So that would be the theory, right? If you were to talk about normative reform. The challenge with preventative care in today's reimbursement environment is nobody accrues the benefit. It's a public good. and so the incentives for any preventative care are few and far between. And in general, preventative care is kind of expensive, because preventative care outside of the vaccines and some kind of basic lab tests, most of it is geared around leading healthier lives and behavioral change. And behavioral change is not easy, and it's usually not very cheap. go to a coach, go to a gym. It takes time and money from somebody to convince you to do something differently. So preventative care is generally poorly incented in the healthcare system. And so the only way you get it done is it's the right thing to do. And so with us at Galileo, with us at One Medical, with most clinicians, we do preventative care not because it's economically sound or we get paid well for it. It's because it's the right thing to do. And not every provider group has the resource or intensity to manage preventive care, but it's an important thing to do. So high quality groups do it because it's the right thing to do, but it usually doesn't necessarily have an economic incentive that makes it happen. In fact, it usually is sometimes a disincentive to actually do high quality preventative care. And everybody says, well, geez, if we just paid for this preventative care, we'd save all this money. It's kind of not true. You'd save money 10 years from now, right? Meaning your obese people will be less likely to get diabetes and less likely to have kidney disease 20 years from now. But that's why it's a public good. Nobody benefits immediately. And given how short people are in their insurance companies, typically 3 years, nobody's accruing that benefit. So unless it's mandated, which limited numbers of services are, and Affordable Care Act kind of did a lot to shore up the base foundation there, it's really hard to make it work.
That's really insightful. Your categorization of the different types of public good and then all the way up to private is really helpful. Shifting gears, Elizabeth McGehee has a question here, which I really like. Have elements of the French healthcare model recognized globally for quality of universal coverage informed your thinking and vision as a health entrepreneur over the years? And I have to say, in my own everyday experience, talking to folks from other countries when they kind of hear how American healthcare works and how, when you get sick, you open a GoFundMe and hope that your friends donate so that you don't end up on the street. It certainly comes across as a rather absurd way to run healthcare. So please, I'd love to hear your thoughts.
No, it's great. And my probably only regret as part of the young leader experience I had was I was so busy trying to, focus on all the different events and sleep deprivation and socializing that I didn't have enough time to really dig into the healthcare system in France. I mean, outside of the very superficial stuff, but I would have loved to do that deep dive, and maybe in some future state we can. But I can tell you that I've looked at, French, UK, other more socialized programs, and there's a true but not true kind of storyline. Does the experience of more socialized countries where healthcare is paid for through, kind of government sources in general, feel better than the American system? Probably. Is it less inflationary than the US system? Definitively. Is it still hyperinflationary, which means still have a tendency to be more expensive than CPI? And the answer is yes. And so, and I get back to the issue here. So with more, with countries that do more, again, it has too much of a charged term, but, kind of socialized or government-sponsored healthcare system, it definitely has some pros, meaning you don't have to fight for coverage, and there's a base foundation that's pretty good. And in general, preventative care and primary care are better in those systems, right? So that's why the experience feels better. The downside is the specialized care may not be as, as specialized. The access to more esoteric and novel therapeutics may not be as universally covered. Queuing and resource rationing may be more common, right? And despite that, it's still hyperinflationary. And the reason why is somebody else is paying the bill. And when somebody else is paying the bill, that means that in general, it has a hyperinflationary trend, and there's generally there's not as many incentives to do more for less, right? In both the American system and more socialized systems. So in general, in all of these systems, it's to try to do more for more. And that's generally why we see a hyperinflationary system. The only difference between the US, well, one of the major differences between US healthcare costs and other countries is our healthcare system happens to be bolted on to the private sector. And so commercial insurance kind of piggybacks off of the profitability of companies. And that's why we have flattening of wages in a lot of our workforce. And it's because healthcare has basically hitched itself to the profit engine of corporate America. And that's generally been a productive engine, but those productivity gains haven't gone to pay for wage improvement. They've gone to pay for healthcare insurance. And so, again, well-intentioned people through the whole system, but HR benefits administrators are competing for employees. They want to offer richer benefits. God forbid I want to take Stanford out of my network, even though it's cheaper, because I'm not going to win with my employees by taking Stanford, which might be more expensive, out of my network. And so in general, the decision is still the same, but because it's hitched to the American private sector, you end up with a lot more wiggle room to create richer benefits design than a government ration program that's looking at what is in and out. And so because of that, you've seen this kind of on steroids growth of the American system. But it's the same architecture, which is somebody else is paying the bill, and there's no disincentive to kind of think about value.
All right, well, we're running short on time, so I apologize that we won't get to all the questions, but I want to ask one more so that we leave a little time for people to transition to their next event of the day. So I have 5 children, and it doesn't take long rooting around in the medical healthcare system to realize that there's tremendous waste at the billing and insurance and reimbursement stage of the process. And I'm just curious whether you have any insights or technologies or ideas that really home in on that, you know, what proportion of every dollar goes to pushing dollars around as opposed to providing care?
Yeah, this is fun stuff because there's a lot of, you know, mythology around this. You know, people say, oh, it's 50% of every healthcare dollar spent, and that's just not true. I mean, you can make, you know, you can play around with the numbers to make that true. It seems like it because whenever you go see a doctor, you get 5 bills or whatever, right? But that's the way healthcare is organized issue. And then the way it's architected. So the short story is the actual transactional cost of health insurance reimbursement is single-digit percents, right? So when you look at the cost of billing in a medical office, it's single-digit percents as a percent of revenue, right? That's the time allocated. And sure, if you added up all the administrative efficiencies, it adds up. There's a reason why all of these administrative inefficiencies and adjudication processes are there. And it's because if you don't have those, then in theory, healthcare is even more inflationary than it currently is, right? So it's already inflationary. But let me give you the example, right? Right now, health insurance is not insurance. It's an all-you-can-eat consumption product, right? Now, I want to get away from the charged nature of healthcare being a right, right? But in theory, you know, food is a right, but you don't have an unlimited food budget that you can just you can just go and, you know, I got a food program, I can just consume whatever, right? Every American isn't entitled to some all-you-can-eat food program, right? That's paid for through tax dollars or taken out of my wages, right? So the problem is you have a lot of these kind of all-you-can-eat services that aren't really insurance, they're consumption of services. Like when you buy auto insurance, it doesn't include free gas, free auto maintenance, free tires, and when you crash, you get a new Cadillac if you want one, right? Your insurance coverage doesn't cover that because it would be extraordinarily expensive, right? And so because of that, you already have a system here that is hard to manage. And so these bills and adjudication are really ways to control and manage medical expense. And the reason why you're getting bills from all these different places is there's a lot of people with their fingers in the pie. And at some level, it's accounting for all these things. Remember we talked about the unit of measure, time-based billing, video visit, whatever. Somebody in the insurance company business is trying to organize all of your consumptive behaviors into boxes that can be adjudicated by a code to say appropriate or inappropriate. Imagine if all your food consumption behaviors were adjudicated similarly. You're only allowed 2 bagels for breakfast, and your benefit doesn't cover all you can eat granola. You can only get yogurt every 2 weeks, right? And so if you consume yogurt again, then you have to submit a claim, and then it comes out of your deductible, so you have to pay for the granola out of pocket. So that's kind of what we've done to the healthcare system. So every consumptive behavior is being adjudicated, and that's why it seems really odd and frustrating and micronized. But that's kind of why.
Oh, that's a really, really excellent explanation. Well, thank you so much, Tom. It's been great to learn from you today. I hope everyone enjoyed the discussion, and I'll turn it back over to the organizers.
Great. Thank you so much, Tom, for this discussion and leading us through the healthcare landscape. Thank you also, Anne, for your excellent moderation. We really appreciated this. For those of you on the call, I wanted to flag our next public webinar, which will be held on February 11th, and it will be on the topic of building a brighter New York City with Catherine Wild, President and CEO of Partnership for New York City. So thank you again, everyone, for joining. Bye-bye.
Thanks, everybody.